Good morning, everyone. Thanks for joining the session. I know it's been a busy morning, and obviously to stay in a room in Gold Coast is probably not the easiest thing, right, while the beach and the weather is so nice. So, but we're here to talk some cool stuff today. I know you guys are heading into the winter season where upper respiratory tract infections are quite common and prevalent. So we have Professor Richard Harvey today to talk about upper respiratory tract infections and the role of high-dose menthol. But before we get going on that, I wanted to introduce Professor, who is actually joining us bright and early from Bangkok. He couldn't make it in person here, but he still was kind enough to be with us, virtually at least. So Professor Richard Harvey is the head of rhinology and skull base at UNSW. He's also the program head also a professor at UNSW and Macquarie University, a president at Australian and New Zealand Rhinological Society and Australasian Academy of Facial Plastic Surgeon. He's an acclaimed researcher as well. He's an editor-in-chief of Australian Journal of Otolaryngology, also contributor to Rhinology Journal, has been a recipient of several awards, namely Australian Society of Otolaryngology Head and Neck Surgery Medal, as well as ESR Hughes Award for Royal Australasian College of Surgeons for contributions to this profession. So without further ado, I would invite him to deliver the talk, and post that we'll be moderating a session on this topic. And if you have any questions, please do post it online. Thank you.
Good morning, everyone. I hope you can hear me okay.
Yes.
Now, my name's Richard Harvey. I'm an otolaryngologist by training, but I actually only look after patients who have disorders of the nose and sinuses. And that makes me a rhinologist. But as much as I am a surgeon, I really see myself as an immunologist and researcher of the upper airway. And I am really disappointed I can't be here in person, because the role of nasal breathing, how we perceive nasal breathing, is so important. And that's what we're going to talk about now, is the sort of pathophysiology of nasal, the sensation of nasal breathing, and some of the interventions we have to help patients who feel a sense of congestion. Here are my disclosures, and obviously I'm a paid speaker today for P&G, but I don't think any of this affects the content of my talk. The nasal breathing, there are no mechanical airflow receptors in the nose. It's not like tactile receptors on your skin when you stroke your skin. We don't perceive airflow this way, and there have been sort of theories touted around, since I was a medical student about how we perceive nasal breathing. One of them was this idea that as air flew through the nose, it created a negative pressure, the so-called Bernoulli effect. But really, a stretch receptor, there's really been no convincing evidence for it. But in recent 20 years, the concept of thermal cooling, so the perception of temperature through receptors called TRP receptors, has become really the mainstay of our understanding as to how humans perceive a sense of nasal breathing. And these receptors that detect the thermal characteristics of our mucosa are on the C fibers of trigeminal nerve endings. So this is really our current understanding of what goes on in the nose. So here is a nasal cavity on the side. Underneath all of this, we have a very complex nerve system here. This is the trigeminal nerve endings. They fill the nose. The trigeminal nerve endings are very dense in the nose. It's important, the nose, as being one of the entry points into the airway, has a very high neural density. This is why we can produce a sneeze. A sneeze and, say, a watery nose reaction are part of the very initial defense mechanisms our airway has when we come into contact with noxious stimuli. So this is why we think, teleologically we've developed this way. The same is probably true for cough. We have similar TRP receptors and laryngeal sensory density in the larynx. This helps us to clear the lower airway very quickly. And the upper airway is the same. Now, as we breathe airflow through the nose, it creates a cooling of the mucosal surface, and a TRP receptor picks this up as a cooling sensation and stimulates our trigeminal nerve. Now, the way this works is that airflow is acting as a radiant or an evaporative cooling effect here in the mucosa. So as airflow goes through, we get the mucociliary layer. There's a layer of mucus that constitutes both some thicker mucus as well as some finer fluids in amongst the cilia, and you get evaporation, and that causes the cooling that we perceive. And I think even when we take a breath in on our own, it feels more open than when we breathe out. And that's because the air is cooler as it comes in, and we get a greater cooling gradient drop on the inspiration phase as opposed to the expiration phase. Now, this also underlies why some of these products work. So products that are designed to help relieve nasal congestion that contain menthol, eucalyptus, tea tree, or camphor, they actually stimulate these TRPM8 receptors, and it actually creates this sensation of nasal breathing and a less congestion in the nose. Now, the TRP receptor family, is a pretty significant discovery in medicine. Julius and Patapatane discovered it many years ago, but they were recently awarded the Nobel Prize in 2021 for their discovery. So the TRP family, the Transient Receptor Potential family, includes a heat and pain sensory receptor. Now, the TRPV1 is actually involved in the nose as well and in the airway. And in my world, it produces pain and pressure in the nose. This is why when we get a cold or a virus, we get a sense of pressure across our face, but it's not a sinusitis, it's just pain and pressure. And we see this in the Australian community, for instance, when there is bushfire smoke in the air. Many patients will complain that, the smoke's in the air, it's playing up with my sinuses, and they get pain and pressure. But then 2 or 3 days later, when the smoke's gone, they're well. They didn't really have sinusitis for those few days. What they had were these TRP receptors being stimulated by smoke in the air. And of course, patients perceive it and think they've got some sort of sinus disease. And of course, the cool or cold sensory receptors, the TRPM8, is really what's been implicated in our sense of nasal breathing. So how does it work? Now, menthol is probably the most commonly described agent that can activate this channel. I mean, menthol comes from, it's a natural product derived from mint. We've got an expert in Jaspreet who's here who can probably tell us a little bit about more other sources of menthol and how it's formulated for pharmaceutical grade use. But it stimulates these TRPM8 receptors. It releases a cationic protein that causes a potential change. And they're located not just in the mucosa, but oral mucosa and on the skin as well. And they produce this sort of cooling sensation. So here, obviously on the skin, it's mediated through somatic nerves, but in the nose, it's mediated through the trigeminal nerve. Now, this is really important to understand what's happening here, because menthol, for instance, when it stimulates this TRPM8 receptor, it doesn't actually produce any decongestion of the nose. So although patients feel a sense that they can breathe better, it doesn't actually change the nose in its physical characteristics. And likewise, when it affects the skin, although patients perceive a cooling sensation on the skin, and that can be of symptom benefit, it's not actually causing a drop in temperature in the skin. And this is really important to understand here. Now, we don't fully understand, I think menthol it is a natural product. It is primarily excreted in the urine, and a lot of the pharmacokinetics are not fully understood. But from its effect, whether it be on skin, oral mucosa, as well as respiratory mucosa, the TRPM8 receptors do produce this sort of cooling effect without there being a corresponding physical change. Now, if you said to me, how do we put this into place then when it comes to understanding breathing? So this is actually just from a publication of ours. We talk then about what's happening in the nose. We really have two issues in the nose then. People have what we call a radiant cooling abnormality. So a radiant cooling is for instance, you're just not getting airflow through the nose. And this could be things like a septal deviation, could be as simple as a mass in the nose causing a blockage of airflow, and therefore the evaporative cooling effect of airflow and the airflow through the nose is affected. That's very simple to understand. But the part that I think is a little bit trickier for many patients is to understand that mucosal vasodilatation, so blood vessel engorgement along with inflammation, produces a distortion of the local TRP receptor environment. And so if you have chronic inflammation still occurring in your nose, such as allergy or other rhinitis conditions, they produce congestion of the blood vessels, which increases temperature, and this impairs TRP receptor activation. And also it changes the mucus rheology. The mucus gets thick, and this impairs the evaporative cooling power of airflow. And this is why it's not possible to simply just, as a surgeon, cut your way out of nasal blockage. You can't just create more and more space. You have to, at some stage, change the underlying mucosal health if you're going to give people a true sense of nasal breathing. Now, there is, of course, a sensory component, and we've talked about that mucosal change has to be detected by the trigeminal nerve. And there's even menthol detection tests that have been used to see how sensate some people are. There's thought that there may even be a group of patients who lack sensitivity here. But a big part then is the psychogenic component. We do see in the upper airway patients that are like the hyperventilatory patients of the lower airway, where anxiety, somatic symptom disorder, and hyperventilation overlay what's happening, and patients can get very distressed, a sense that they can't breathe through their nose or breathe through their lungs, just like hyperventilation patients do. And there is a real overlay here that's very important to marry into interpreting what's happening in patients, just like respiratory physicians are very aware of patients who have hyperventilation syndromes rather than just truly being short of breath for pathophysiologic reasons. And then, of course, those three components come together in our perception of nasal breathing. Now, let's look then about our ability to change this. So in the upper airway, you can relieve nasal blockage and congestion through products like camphor, menthol, eucalyptus oil, and it actually also acts on the lower airway to reduce cough. Now, here's a couple of studies, and I'll go through just my last few minutes here. A few studies. One of them was done on patients who have a viral upper respiratory tract infection. There was over 50 patients in an RCT here. And what they compared was vapor rub, which is sort of a camphor, menthol, eucalyptus solution, and its base, so just a petroleum base. And they used the primary endpoints of a symptom VAS for both nasal cooling, which you can see on the left-hand side, and really the effect here of the perception of cooling happens very quickly from as early as 12 seconds, and it's prolonged. It lasts right up to the end point of this study, which was 15 minutes. And here, likewise, for the relief of nasal congestion, the relief of nasal congestion came on pretty quickly afterwards. So cooling effect happens almost immediately, and within a minute, you've got a sense of relief of nasal congestion. Menthol does reduce cough. So this is another study looking at healthy patients. Respiratory doctors and scientists have lots of ways of inducing cough. One of them is citric acid being inhaled into the airway. This was 20 patients in an RCT where they were given menthol in a eucalyptus base versus two forms of placebo, pine oil and air. And here they showed that throughout the whole induction of cough, that really there was a relief of cough from menthol over pine oil and placebo throughout the entire time points. And that effect of those drugs actually lasts up to 4 hours after the challenge. So you actually get a reduction in cough from saturation and stimulation of these TRPM8 receptors with menthol over pine oil and air. Now, how does this translate into symptoms? This has been explored a couple of times. One of them is to look at pediatric sleep. So this is, once again, these are patients with viral upper respiratory tract infections, 2 to 11 years of age. And there was 138 patients in this study. It was an RCT looking at, once again, a menthol, camphor, eucalyptus base versus the petroleum base versus no treatment. And the primary endpoint here was a parental questionnaire over 2 nights on cough severity, cough frequency, the ability to sleep was recorded by the child, and then once it's recorded by the parent. And that's the A, B, and C graphs there. And pretty much the summary of this randomized trial was that actually at all measures of symptom and sleep improvement, those that were taking the sort of menthol, camphor, eucalyptus treatment over the base and over nothing at all had a benefit in terms of both symptoms and sleep. That's been repeated in adults as well. So this is another study looking at sleep quality. a very common inclusion criteria, viral upper respiratory tract infections, 100 patients, RCT, looking once again at a base versus a menthol eucalyptus camphor mixture. And the primary endpoint here being a subjective quality of sleep questionnaire. And they really asked two questions, how did you feel your quality of sleep was and how refreshed you were in the morning? And a really significant improvement in symptom scores there between those that were taking the treatment versus essentially a placebo group. So if I had to summarize here, nasal airflow is mediated by mucosal cooling. The TRPM8 receptors mediate this, and it's really a sensory perception of cooling of the mucosa. And we know that there are natural compounds. Menthol's not the only one. It's perhaps the most well-known one that can stimulate this. And it's now sort of been included in a lot of treatments that are designed to help give patients relief, especially for really common things like viral upper respiratory tract infections. So topical inhalation menthol and other similar TRPM8 agonists are used to help improve the sense of breathing. Sometimes they're even combined with things like decongestant sprays. They relieve congestion, they can reduce cough and improve quality of sleep, both in children, adults, and parental opinion about sleep. And so, look, I think these are really important things that we begin to add to our armamentarium when we talk to patients about getting symptom relief, especially from acute respiratory events when we're really trying to move away from patients seeking antibiotics and move them on to treatments that are going to help them and really avoid systemic exposure to therapies that are likely to be ineffective. And look, on this note, I'm going to hand over to Jaspreet because I know he's the expert in the field and we're very fortunate to have him here. And I know he's probably got a few questions for me as well I do for him.
Yep. Thank you, Prof. Harvey, for that interesting talk. A lot of the pharmacists and growing up, I also thought menthol was a nice aromatic ingredient that you put in your diffusers with eucalyptus and all these oils. I'm sure that feels nice, but there's obviously a lot of science behind, as Prof. Harvey just mentioned, right? And somebody just won a Nobel Prize for it, so it's not a simple science either, right? So that's an important thing. I got a question from the room, Prof. Harvey, which somebody asked, why is nasal breathing so important? And I believe the individual is asking, why is nasal breathing so important in upper respiratory tract infections, I presume?
Yeah, from a symptom perspective, you may look at some of the data and say, look, if we give patients menthol, it relieves their sense of nasal blockage. Why do they sleep better? Because we're not physically changing the dynamics of airflow. When people have a blockage, Jaspreet, from an upper respiratory event, they actually rarely have complete, like a true physical blockage of airflow. It may be slightly restricted, but it's actually rarely restricted enough that it causes a physical issue. It just feels heavily congested. And that's because of the inflammation that's occurring on the inside. And so a lot of the relief of nasal blockage, especially here, apart from making people feel more comfortable, it helps to distract the mind from the sense of blockage. And I think probably sleep induction is greatly improved. People aren't focusing in on their sort of blocked nose or sensation of blocked nose as they go off to sleep. And so, although no one's going to end up in hospital from a blocked nose, people do love it in the sense of having a free breathing nose, a sense of clarity in their airflow. It just adds to quality of life, and things like some of those sleep outcomes are part of that.
Yeah, couldn't agree more. And on that note, I also wanted to share, there was another study on anecdote and the point that Prof was mentioning on, the subjective perception of relief. And one of the studies ran, which actually demonstrated that. So how you run these nasal congestion studies is, one, you can actually have a rhinomanometer, which measures the pressure of airflow or the resistance to airflow that goes through your nostrils. And you can measure whether there is an objective change in it or not. And some of the nasal decongestants like oxymetazoline would show a difference. But for ingredients which cause a subjective perception of relief, often in an objective measurement of rhinomanometer, you do not see any resistance change to airflow. So in a study that was run, so there were two legs, people with nasal congestion. Half of them were put on Vicks Vapor Rub, half of them were put on they were running on a treadmill. And exercising is known to show, just how the body reacts to more oxygen demand. It's known to have more airflow. So when those people with nasal congestion went on these two legs, the ones that were on this rub with menthol, camphor, eucalyptus, for both of them, if you look at the objective measurements, the people who were on the rub, there is no change in the objective measure of the resistance to airflow on the rhino manometer. And the people on the treadmill, they had an objective betterment in the airflow. When they were asked a subjective question, how congested or decongested do you feel, what do you think people who were on the treadmill answered? No decongestion. And what do you think people on the...
I was about to say that they're probably even worse. They probably feel like they're struggling. Pushed.
So reported to be no change on that study, but people on the rub, what do you think they said? They were all decongested, right? So this goes back to the point on how TRPM receptors get activated and how the products do provide relief from subjective perception, subjective relief from nasal decongestion. There was one more question from the room asking what was the menthol dosage in the cough study. So for the rub, the study was run in adults. The adult study showed 7.5 grams of the rub, which is roughly about 2 finger scoopful. So when people come into your store asking for such decongesting rubs like Vicks Vapor Rub, that's the dosage for adults, roughly about this, 2 finger scoopful. And for the children's study that was ran by Ian Paul, he's a very well-known pediatrician in the States, that study for nocturnal cough in children included a dose which was about 3.5 grams. So it's roughly about 1 finger scoopful. So moms can do that. There's one more question, Prof. Does menthol have a role in patients with COPD and emphysema?
No, in my opinion. There may be some, I think a lot of patients who have chronic airway conditions, their cough is not is as much a productive cough. It's a mucus cough because of mucostasis and problems in their lower airway. And their perception of shortness of breath and things come from a true oxygenation and carbon dioxide issue. So, they may have some relief, but this is not the target group. Really, the target group is really much more basic than that. It's really the vast majority of patients who they have normal airways, and then they go through phases where they get very blocked from rhinitis, and whether that be an allergic rhinitis, a viral rhinitis, and of course this, when people have viral rhinitis, they get a viral respiratory tract infection in general. And if you look at some of the treatments, Jaspreet, that, if we're trying to move away from, making sure patients aren't seeking antibiotics inappropriately here, there are obviously typical decongestant oral and sprays that can be used. There are analgesics that help with fever. There are intranasal corticosteroid sprays, but most of those that are available over the counter, they take about 4 to 7 hours to actually bring about any improvement in mucosal inflammation. And so it really leaves a gap as to how do we then provide relief of nasal blockage in that zone in between. And it really is then down to stimulating TRPM8 receptors with or without some decongestion physically of the nose that I think is where you are likely to provide the biggest improvement in symptom relief.
So how long does it take? Immediately. So the study that you saw, Prof. presented, the sensation of nasal cooling was reported within 12 seconds, and the perception of nasal decongestion was reported within 62 seconds. So it's presumably everybody in this room has used those kind of products at some point in time in your life. I guess the moment it hits either your skin or your nasal mucosa, or your throat areas, you get the cooling or the warming, depending on which receptors the product activates. There's one more question, and it's my favorite. I get that asked a lot of times. Rubbing menthol and such rubs at the bottom of infants, I would call it children. Infants are contraindicated from using this product, so 2 years and above. Feed to reduce decongestion. Is that a myth or a truth? How many people have done that in the room on their children? So probably, Prof, I'll go first with this answer. I guess the point is the mechanism of action remains the same. It's the vaporization of these aromatics, these medicinal aromatics, and they have to hit your nasal mucosa or your laryngeal mucosa. I guess for children, because they're short, they're not as tall as us, I guess the vapors can still travel to their nostrils as fast versus us as adults. Obviously, we are much taller. But these ingredients, as Prof was mentioning, they do have some benefits as counter-irritants and pain-relieving benefits when you have sore muscles. So it does help in adults when you rub it on wherever the achy areas are. Anything to build there, Prof. Avi?
No, I completely agree with you. I mean, that's why it works on the skin, right? But can I ask, we talk about menthol, but it's really, there's a mix of products that produce stimulation of the TRPM8. I know that I think some of the Vicks products have camphor, eucalyptus, is that correct? And I think it's just not limited to that set only, is it, Jaspreet? I think things like tea tree oil and peppermint oil, these are all things that sometimes we hear about in traditional treatments, but this is how they're bringing about that symptom relief. Is that correct?
Absolutely. I mean, that goes back to the point that there is enough science behind these traditionally considered as aromatic or aroma ingredients. So, Prof, there's one more question I have here. In terms of management of sore throat, especially when you have upper respiratory tract infections, how important is to intervene early with these therapies, and what's your suggestion to the pharmacists in the room?
Yeah, I think there's, we have lozenges that contain anti-inflammatories. I think the idea of using antibacterial lozenges, it doesn't make sense in my mind. Most sore throats are viral in origin. Anti-inflammatory, we're in the same zone as using intranasal corticosteroid sprays during an acute event. While they are helpful and they're indicated, they just take a long time to work. And I think the same is true for the sore throat. Although sometimes anti-inflammatory treatments might actually help, probably just providing symptom relief so that patients can get on with their daily activities is the critical thing. And then that relies then on using systemic analgesia and local treatments like stimulation of TRPM8 receptors. And I think doing it early and allowing patients to get on with the swallowing, eating, talking, having to breathe through their mouth and their sore throat is what we're trying to do in terms of symptom relief. I mean, most upper respiratory tract events are going to resolve spontaneously. They have a time course. And I think our role as healthcare professionals is just symptom relief, rather than really trying to change the duration of the whole episode.
Agree. Is that all? Is that the time if you have? Okay. So just on a parting note, thank you for your presence today. We'll be at the Procter & Gamble booth if you have any more questions about these ingredients and the ingredients that go into Vicks products that manage upper respiratory tract infections. Our team would be happy to answer that. So see you there. Thank you.
Thanks for having me.
Okay, we'll be back in 5 minutes' time for making dry eye easy.